Dr. Randy Schapiro, who will speak to us about fatigue and transverse myelitis and related disorders. Dr. Schapiro has authored numerous articles and written some fantastic books about the symptomatic care of patients with MS and related neuroimmune disorders. And not only is he extremely knowledgeable, but he's also extremely entertaining. So you're in for a treat.
Well, thank you, Peter. I don't know if I can be too entertaining with this topic, but I already warned them that I'm going to stand beside here because I don't like walls, and the podium's a wall, so they have to move the camera. That's the first bit of entertainment we get to watch. I appreciate the opportunity to talk to all of you. It's always fun to talk to groups like this. And I must admit, I do it with a little trepidation because when I got here, I wasn't entirely sure of what I was going to say, and then when I started talking to people over lunch, I started asking questions. I asked questions, didn't I? And I said, what is transverse myelitis anyway? And because, I'm not a kid anymore, and I've been a neurologist for more years than I'd care to say, and I never really considered it much of a disease. It was always a symptom of something else going on in the same way as seizures. Seizures end up being called epilepsy if we don't know what the cause of it is, but we look for a cause. We try to figure out what it is. And then I was handed the assignment of fatigue and transverse myelitis. I'm not sure I know what fatigue is either, let alone transverse myelitis. There are lots of causes of transverse myelitis, and so here are some of these causes. Para-infectious, post-vaccinal, autoimmune, and you notice multiple sclerosis is listed into that list of autoimmune diseases that we have there, and so that made me feel a little more comfortable about this. Sometimes cancers cause it, sometimes vascular problems cause it. How many of these then have fatigue associated with them? Because not all transverse myelitis has fatigue associated with it, and I don't know the answer to that. And as I looked, I'm not sure that anybody knows the answer to that, because fatigue can be associated with any and all of these diseases, but sometimes it's not. And so I'm not sure how to break this out. So when you're not sure, you fall into something that you're more comfortable with. And so I know there's fatigue and multiple sclerosis, so I'm going to use that as the prototype. And I notice everybody else is doing that too, so I feel real comfortable doing that. But I recognize that it may not fit each and every person with their individual style of transverse myelopathy or myelitis. But it is common in multiple sclerosis. It is the single most common symptom that we see in multiple sclerosis. It is the single most disabling symptom that we see in multiple sclerosis. So if you happen to have a transverse myelopathy and not have multiple sclerosis but have fatigue, there's no doubt in my mind that it is going to be very disabling and very, very much of a problem. It's seen in 78% of people with multiple sclerosis. Nearly 2/3 of them have it on a daily basis, and it can cause significant disability. It interferes with physical function. It interferes with daily living. It has an impact on their mental health. It gets in the way of their normal sleep patterns. They lose control of their disease because of fatigue, and they lose control of their life because of fatigue. It leads to unemployment, and consequently, eventually, Social Security had to come to the conclusion that people who have MS or MS-like diseases can, in fact, be disabled on the basis of their fatigue. They look so good. Now, the problem is that we see so many different kinds of fatigue. And I don't care whether you have transverse myelitis or multiple sclerosis, you have normal fatigue. Everybody who works hard gets tired. And sometimes when we work hard and get tired and have a disease, we attribute it to the disease. But in fact, that's the natural pattern. So when we see somebody with normal fatigue, we treat it with applause. We are happy that they're able to work like that, and we understand that. We also see in both transverse myelitis and multiple sclerosis a short-circuiting type of fatigue. It's really pretty easy to understand. You can see that nerve firing and firing until it blocks because it's not healthy. In the case of MS, we've already seen the demyelination process and the axonal process, the nerve process, but it can be from other causes as well. So you start out walking and you do pretty well, and then you begin to get that neuromuscular fatigue. It just doesn't work anymore. So that we treat with rest and graded exercise to try to build up capacity. Speaking of exercise, people who have neurologic disease often don't do that. So they become deconditioned. And then they wonder why they poop out when they go to do something, because they're just not in shape. If any one of us did that we went out to do something big without having trained, we'd understand it, but sometimes people don't understand it when they're so close to the situation. So deconditioning is a third type of fatigue that we have to deal with. A fourth type of fatigue occurs across the board as well. If you're not sleeping well, if you're not eating well, if you're not feeling well, you may in fact be depressed. And with that comes fatigue. And we have to understand that and get the appropriate treatment for that aspect as well. Having said that, the most common kind of fatigue that we see in MS isn't any of those. It's a fatigue that we call lassitude. It's an overwhelming tiredness that hits people for no particular reason. And this is where it might deviate some from some of those people with transverse myelitis and not from others, depending on the cause. Because this is a little bit harder to understand. This must be a neurochemical process from what we learned from it later. You can be feeling very well, not depressed. You can be in shape and then just get so sleepy that you just have to take a break and take a nap, and then you take a nap. You feel better. And then a couple hours later, you're back into that same cycle again. Lassitude, overwhelming tiredness, hard to understand. So if you look at the top of this particular slide, you have multiple sclerosis. You could substitute transverse myelitis. There's a physical health problem on the right. Some things cause fatigue and get involved because of the physical aspects of your disease. And then you may not be sleeping well because of the legs jerking or bladder problems, and so that causes fatigue. Then, of course, you have normal fatigue at the bottom that we all have to deal with. Then you have the psychological fatigue that we all have to deal with, and people with chronic disease have to deal with it in spades. And then you have to deal with the environment. And so it's no wonder that fatigue is so common in these neurologic diseases. It's common because we have the primary causes, the actual disease itself. It's common because we have the secondary causes, the drugs we take, the deconditioning, the psychological process, all lead to fatigue. So as I said, it is the single most common and the single most disabling symptom in MS. 97% of patients will report that they have fatigue. Half of them will tell you it's their worst symptom. It's reported more than any other neurologic symptom in people with multiple sclerosis. So when we go to treat fatigue, it really takes a team to do it properly, to do it when it's the severe kind of fatigue properly. It takes the occupational therapist to understand the activities of daily living. How do you dress, eat, bathroom more efficiently, more effectively, more appropriately? It takes the physical therapist to try to work out the neuromuscular fatigue, decrease the spasticity, improve the patient's efficiency at functioning physically. It takes the psychologist, social worker, whatever it happens to be, to work on the psychological aspect of the disease and work on the depression and circumstance like that. And then we have drugs that we probably need to use in some people with these kinds of fatigue. I'm always asked about exercise. Where does that fit into this whole thing? Because I'm told by so many, whether it's transverse myelitis or whether it's MS, when I exercise, I get tired and then I get fatigued, and so what good is that? How does that work? And the reality is that's the way we all thought for years and years and years until we began to learn something about exercise. And I've always come back to the fact that when I was in high school, a long-distance run was a 1-mile run. That was a long-distance run. Do you think I could run it? No way could I run a 1-mile run. You know who broke the 4-minute mile in the first 4-minute mile? Who? Not Jim Ryan. Roger Bannister. Roger Bannister. And Roger Bannister, for some of you, that doesn't mean a whole lot, but Roger Bannister went on to have a brilliant career as a neurologist from Great Britain, and he got knighted, Sir Roger Bannister. He's now retired. He was a person who got very interested in neuromuscular disease, but that was a long-distance run then. And now, of course, the long-distance run is, what, a marathon? Maybe it's an ultra, maybe they do 2 marathons, 3 marathons, who knows what. And this guy who couldn't run a mile when he was 16, 17, now is age. And now I can run 10 miles without blinking. How does that happen? How does that happen? Well, we have to learn how to train. We have to apply the exercise appropriately. So in MS, it was very hard to do until a skier came along. His name was Jimmy Huga. And Jimmy said, let's learn something about exercise in MS. He didn't know it, but he got people together to try to look at that. How do we exercise in MS? And we started understanding that you have to keep a balance between your growth in terms of exercise and overdoing in terms of exercise. Training became important. And we began to understand the role of aerobic exercise in keeping oneself fit and less fatigued. So we had to do an exercise prescription. You have to know what your goal is, and that determines the type of exercise. And then you have to know how hard to exercise, how often to exercise, how long to exercise. And obviously, these are individual circumstances. If you apply the principles of training that we've learned in the past 2 decades to neurologic disease, you can use exercise to build endurance and to decrease fatigue. But if you just jump in and do it, it's destined for failure. Let's look a little bit at the pathophysiology of this very complex and poorly understood symptom, fatigue. It's present in all stages of MS, and I suspect it's present in all stages of many neurologic diseases that involve the central nervous system. It doesn't correlate very well with a lot of things. It doesn't correlate with the disability of individuals. It doesn't correlate with whether they're men or women. It doesn't correlate with their age. It doesn't correlate with the kind of MS that they may have or how long they've had MS. And it doesn't correlate with their MRI. It's an amazing symptom that goes outside of itself. It has some relation to depression. We talked about that, and it doesn't have a lot of correlation to cognition, but you can get tired. Talking about it, you can get tired too. It's very biologically complex. Some neurologists believe that it all has to do with these central nervous system hormones that we call cytokines. We've been talking a lot about those, that are produced by these cells. The interferons are some of those, the interleukins, and some of these cytokines, these hormones. They may have a relationship to that, but we really don't know. I believe it must have a neurochemical relationship, but I don't know that from deep basic science studies. It just makes sense, which I'll come to in a moment, because neurochemicals that we give people seem to have an effect on that kind of fatigue. It obviously comes from many different places. And if we look at the metabolism and nerve conduction in the central nervous system, we see that it has some correlation with fatigue and increased energy demands. So that if we look at a PET scan here, we can see that the people who do not have fatigue have a different type of scan from those people who do have fatigue, giving us some indication that there's a neurochemical process going on with this lassitude, this overwhelming tiredness that goes on. So it must have something to do with the inflammation, demyelination, axonal injury, the nerves breaking up. It has some effect with cognition, and it has some effect with metabolism. The issue that we always run into is, how do we measure this fatigue? How does Social Security tell whether you're tired or not? How does your spouse tell whether you're tired or not? Sometimes one look can tell, but not for Social Security. They can't see that far. But your spouse can tell with a look. So we have fatigue severity scales. These scales are very tough scales. They're very hard because they're paper and pencil scales. They don't really give that inside bit of fatigue. But I just thought I'd throw the scales up just for you to get an idea of the measurement of how we measure fatigue. This is the fatigue severity scale, series of questions that you answer. This is the modified fatigue impact scale, which gives you some subscales. So you can talk about physical function, you can talk about cognitive function. We get some subscales to this, psychosocial function. So we have a different scale that allows us to look in an expanded way. And then you can do this visual scale where you just slash along the line where the fatigue expands. Fatigue and sleep and wakefulness all seem to come to run together. And so we look at the brain for our answers. And we recognize that there are different areas in the brain that have different roles in keeping us awake. As you move to the front of the brain, to your left, there's more normal wakefulness. And as you move more deep into the brain, is a different type of neurochemical aspect to our fatigue. So we have different kinds of activity going on with different neurochemicals in the brain. Well, this slide says I've run out of green pills, so I suggest you take the yellow one and the blue one together. And this is to lead me into the fact that we don't know what's going on in fatigue, but we have pills for it. We have pills for basically everything. And so we have a pharmacologic management that we use to try to treat the fatigue that occurs in MS or not MS for that matter. Most patients who have this severe types of fatigue, I don't care whether they have chronic fatigue syndrome or whether they have MS or whether they have transverse myelitis, will require a medical approach and a non-medical approach. Rehab, medicine, to work together to approach the fatigue. There was a doctor in Halifax, Nova Scotia, who had MS. He was a family doctor many years ago. This family doctor took care of people who had the flu one year. And there's a drug for the flu called amantadine. It's an oral pill that you take to prevent the flu. So he was afraid he was going to get the flu. So he took amantadine. And his fatigue went away. Well, that sort of struck him as strange. So he decided to do a study. What would you call this? A phase 2 study, I guess you'd call it. Maybe it was a phase 1 safety study. Well, it was a phase 2 study. And so he decided to go off the amantadine. He went off the amantadine, the fatigue came back. He went back on the amantadine, the fatigue went away. So he went to Dalhousie University in Halifax, Nova Scotia, and saw our good friend Jacques Marie and said, you know, this is going on. And Dr. Marie said, well, let's do a study. Randomized, double-blind, placebo-controlled clinical trial on amantadine. And lo and behold, it worked. This medicine, which has an effect on Parkinson's disease as well, is clearly a neurochemical. It's a dopaminergic, anticholinergic medicine. It's a neurochemical, antiviral, anti-Parkinson's agent. And a third of the patients got better with this medicine compared to placebo. So we have been using amantadine now for almost 20 years for this kind of fatigue. Generally, it's well tolerated. Occasionally, it causes some side effects. One of the side effects I like to tell people about is sort of unusual. It's called livedo reticularis. It's a funny pattern of veins in your legs. It looks like spider web in your leg. And if you don't know that it's caused by amantadine, you think there's something circulatory going on. And believe me, I have no idea why it does that, but it does do that in some people. But basically, it's a safe medicine, easy to take. We give it at 100 milligrams twice a day. Give it during the day, and a third of the people who have this kind of fatigue will feel better on that drug. Then we had another drug. The idea being that you can stimulate the brain, and so we have drugs that are stimulants. They're a little scary because sometimes their street value is more than their value at home. But there is a drug called Cylert. And Cylert is a drug that stimulates adults and it calms hyperactive children. So it really was a drug for hyperactivity in children, but it stimulated adults. And so for 20 some odd years we used Cylert carefully because it has some abuse potential. When all of a sudden, in 1999, the FDA decided to survey people about liver disease and liver failure and found a few cases of liver failure, not many, a few of liver failure, and decided that this drug was unsafe. And then they decided it was really unsafe. Now, I can tell you, all of us neurologists used it for 20 years, never had a case of liver failure. Matter of fact, we never checked liver function tests. Maybe that's why we never had liver failure. Things seem to go pretty well. So all of a sudden now we're told that if you want to use Cylert, you have to do liver functions on your patients every 2 weeks. And that they have to sign a release that they know. So this drug is available. Nobody uses it anymore. It turns out, interestingly enough, if I sound a little sarcastic, it's because I am. it turns out that all the cases of liver failure were in kids, and all of them were in high doses. But that didn't seem to have any, so we can't use this drug too well, but we used it at a dose of 37.5 milligrams a day. We didn't monitor the liver functions. It worked okay, but it tended to agitate some people. It tended to bother them, but it did work. Now, Ritalin, of course, the prototype, the one that we use for kids that are overactive, will stimulate adults as well. I don't use it, but lots of colleagues do. Maybe I don't use it personally, but I don't use it in my practice because I don't want to monitor it. I don't want to be involved in worrying about who's abusing this drug, but lots of doctors do use it to try to fight fatigue by stimulation. Well, a number of years back came the newer antidepressant agents, and along came Prozac. And empirically, just in treating patients with depression and then using it, I saw that it activated. So I started using it in patients who were not depressed for fatigue. And I found, just by experience, and now some clinical studies back us up, that Prozac and that line of antidepressant, in fact, has an anti-fatigue role in people who are not even depressed. The response is variable, but I found it very, very effective. And then along came Provigil, modafinil. This was a drug that was released for the treatment of excessive daytime sleepiness in narcolepsy, in sleeping sickness. And this has become our best anti-fatigue drug, by far and away, for most people. It's a neurochemical, but we're not even sure exactly where it works. It's been monitored for abuse potential very closely because you'd think it might have that, but it hasn't shown that. It was approved in 1999, and it's been used now in MS now subsequently to that. There was a good phase 2 study that was almost a phase 3 study. That is, this was a dose-finding study that had some blindness to it by Kotil Ramahan and Jay Rosenberg, one in Ohio, one in California, in people with MS. And what they found was that one tablet of Provigil, 200 milligrams modafinil, did better than 2 tablets. And that that one tablet did better than placebo, and that 2 tablets didn't do much better than placebo. Now, the 2 tablets were given at the same time, so that's a different way of giving it than the way we might want to give it, but clearly showed that it was of value. So we put together a working group after this was available of experts in the understanding of symptom management and fatigue and multiple sclerosis, and we talked about what would be our best approach now that this drug is available. And we really felt that it is a first-line therapy for moderate to severe cases, that is, the cases that aren't responding to some of the lesser expensive drugs. That's the drawback with this. It's quite expensive, quite safe, but quite expensive. There is some data that the cytokine-induced fatigue occurs with injections of beta interferon, and that, in fact, Provigil might decrease that cytokine type of fatigue, that hormonal fatigue. So this drug has become our favorite drug, actually, for use. We give it usually at a dose of 200 milligrams a day. We may start it at 100 milligrams a day. Give it in the morning because we don't want to keep people from sleeping at night. It's generally well tolerated, and it does pretty well. I'll tell you a little anecdote about Provigil, and then I'll go to the conclusions, and if there's time, I'll be glad to answer questions. Right after 9/11, I was giving a lecture in Chicago, and I had the lecture was at one day, and I had a 6 a.m. flight the next morning. And back right after 9/11, if you remember back then, you had to get to the airport 3 hours before. That was the rule. And this was in downtown Chicago, so that meant it was 3 a.m. I was supposed to get to the airport. And so that meant I had to get up at 2 a.m. And so I was bemoaning this at the meeting. And I was saying to somebody over lunch, this is really a terrible situation. I was just complaining. I was just, how do you do that? The person said, why don't you take a Provigil? I said, Provigil? That's for my patients. I don't take a Provigil. And he reached in his pocket, and he handed me a Provigil. It was 100 milligrams. So I said, well, okay. Next morning, 2 o'clock, I took the Provigil. And I'll be danged. At 3 o'clock, I was wide awake. I went to the airport. I was just fine. I wasn't agitated. I was just fine. 6 o'clock, I got on the plane. I was fine. 7 o'clock, I got off in Minneapolis. I was fine. At noon, I was amazed at how good I felt. 3 o'clock in the afternoon, I was fine. 6 o'clock, having dinner with my wife, everything was really wonderful. 9 o'clock, I'm thinking to myself, this is really good medicine. At midnight, I'm still wide awake, wondering what in the heck is going on here. At 2 in the morning, I'm thinking, I'm not going to take another one of those. But it does work. It does work, I can tell you that. Fatigue is present in many diseases, and I'm sure it's associated with diseases of transverse myelopathy, although I looked for the data and didn't see it. There are many different kinds of fatigue, and when we go to treat fatigue, we need to distinguish what kind of fatigue we're treating. Measuring it is an inexact science. It's so subjective. I'm feeling tired. Lassitude, the most common and significant fatigue in MS, remains a bit of a mystery, but it must have a neurochemical basis. We can treat fatigue. It is difficult to manage, but with the 3 Ps, physical, psychological, and pharmacological, we can, in fact, help most people who have fatigue with neurologic disease. Thank you.